So I'm just going to start talking about menopause experience in women who've had breast cancer. So I wanted to talk about this because so many women, as you know, are ignored, not listened to when it comes to any hormonal changes. But women who've had cancer often are really ignored, but women who've had breast cancer especially. And this is because people often are really scared about the impact of hormones when it comes to breast cancer. But I went into medicine to look after people, to help them feel better, to enable them to make decisions that are right for them at a time that's right for them as well. So, this half an hour, I'm really just going to focus on choice. I'm not going to be talking so much about the specific treatments for breast cancer, for menopause after breast cancer, because I'll do another session on this. This is really just to be about how to be listened to and what's going on out there. Now, breast cancer is very common. When I was a medical student, it was about 1 in 12 women developed breast cancer. And then when I was a junior doctor, it was about 1 in 11 women. Now it's around 1 in 7 women. So it's becoming a lot more common. And there are lots of reasons for this. But we know HRT prescribing has really reduced since I was a junior doctor. So we can't blame HRT as being the reason for this increase in incidence in breast cancer. There are many factors. We're living longer, which is good, but that increases our risk of all cancers. Certain lifestyle factors such as smoking, obesity, even drinking alcohol, not exercise, can increase risk. There are lots of genetic reasons why people have an increased risk, and some people have an increased risk because of their family. For a lot of women, it is bad luck, actually, and a lot of cancers are picked up really early, which is great, but it means that the prognosis is actually very good. Now, in the UK, there are currently around, this is an estimation, around 700,000 women who have survived cancer, breast cancer in the UK. And estimates say that this could increase to 1.7 million over the next 20 years or so. Now, 1 in 5 of women who've had breast cancer are young and they are premenopausal, so they are still having regular periods. So, there are two reasons really that women have menopause after breast cancer. One of them is, like all of us, we become menopausal because we age. And that will happen, obviously, whether people have had breast cancer or not. So, women who've had breast cancer will become menopausal because they get older. But the other reason often is because of the treatments for breast cancer. So, treatments for estrogen receptor positive breast cancers often include drugs that block estrogen working in the body. And so these can be drugs such as the aromatase inhibitors. So they basically inhibit aromatase working. Now, aromatase is an enzyme that converts testosterone to estradiol. So it's a way of blocking estradiol in the body and in all the tissues as well. And there are other drugs such as tamoxifen, which actually work as a SERM, it's called a selective estrogen receptor modulator. So they partially block estrogen receptors, but also they partially work as estrogen as well. So they're a bit not quite so straightforward as just blocking estrogen. Some women are recommended to have their ovaries removed, and some women have drugs such as Zoladex, which will stop hormones working in the body, and that will block all hormones, so estradiol, progesterone, testosterone as well. And some people have radiotherapy as well. If they've had this is more if they've had a cancer of their ovaries or their womb, then they might be offered pelvic radiotherapy, which is another reason why people might have an earlier menopause due to a cancer treatment. But thinking about breast cancer, younger women often are given treatment to block hormones, and it might be just for a few years. Now, those women will become menopausal due to their treatment. So it will be iatrogenic, as in caused by a drug or treatment, menopause. So it's a false menopause, if you like, because it's not occurred with aging. But it often is more harsh because the women are still having good amount of hormones in their body, and then they're blocked either by the drugs or by having their ovaries removed, and so they often go into menopause very quickly and can cause quite extreme symptoms. And then quite often I see women in my clinic who've had breast cancer 20 years ago. They have had treatment to block their hormones working, so they've become menopausal for maybe 5 years, and then their periods have returned, and then they've become menopausal because they're older. So some women have two menopauses when they've had breast cancer. So if one isn't enough, people can have two. So what we did recently was a study. In fact, we did two studies that have been published that I really want to talk through today, and I'm hoping it will make people think a bit differently about how to talk to women who've had breast cancer, but also if you've had breast cancer, about how you might be able to talk differently to your healthcare professionals. So this was a survey that we did. It was put out through social media. It was put out on my social media, but also through some cancer charities as well, social media as well. So we wanted to try and capture as many people as possible. And these were people who'd had breast cancer in the UK. And we had over 1,000 responders. We actually had 1,195 women who responded, and we could analyse their data. What we wanted to do was look at their experience of menopause, about education about menopause when they were in their cancer clinics. Now, when people are diagnosed with breast cancer and they have treatment for breast cancer, obviously the most important thing is the cancer and the treatment and the outlook and the prognosis. But with time, once the treatment's either finished or nearly finished, then people want to ask different questions. It's not quite so raw. They've had a lot of their immediate questions answered, and they're thinking in the future, which is absolutely really important. So education is crucially important. As a doctor, I feel very strongly that I need to be enabling people to have the right education for them so they can make the appropriate choices for their future health. We're all different, patients are different, what they want to know is different, and the choices that they make about treatment based on benefits and risks will be different as well, and different at different times. But the most important thing is to have knowledge, so then when the time is right, people can ask for appropriate treatment. And there are lots of treatments that are available, but what we found was that a lot of women aren't being listened to. So the first paper, and I'll put the link on my, it's available, and I'll put it on my stories as well, is looking at the patient experience. And this was, like I say, it's a cross-sectional study. So it was just looking at the answers that people gave in the questionnaire. And so what we found was really sad, actually. We found that lots of women are just not being listened to at all. We found that 84%, so the vast majority of women, wanted more information. So they weren't given information about menopause. So this is just about whether the treatments will cause menopause. If the treatments were to cause menopause, what does this mean? How are the symptoms going to occur? What are the symptoms that occur? Are there health risks that occur with menopause? All the answers that I know, all the questions rather that I know the answers to, but a lot of people don't. And so really important actually that people can, have this information properly. So we found also that many women were given a lot of, or having a lot of symptoms. So I'm just going to read some of the stats here because I think they are interesting. 84.3% were concerned about their risk of breast cancer recurrence, which is very understandable, but 76.7%, so nearly as many, were concerned about menopausal symptoms and their quality of life, and 67.7%, so the majority, were concerned about the future risk of long-term conditions associated with menopause. And this is really important. So the longer women live after having breast cancer, the more likely it is that they will develop other conditions associated with aging, such as osteoporosis, heart disease, dementia, and so forth. but we know these conditions are associated with menopause as well, and women want to know more information about that as well. And although it's said that a lot of them were they had over half, so 55.6 had fear of recurrence. 28.2% were more concerned about their menopausal symptoms and their quality of life. So we can't underestimate that. A lot of women, once they've had breast cancer and they've got through their initial treatments, they want to live really full lives and they want to be as healthy as possible. And they want to look very holistically about how they lead their lives and any risks that they might have following having the treatment or outcomes from treatment such as menopause as well. And so we know that there are a lot of impact of menopause symptoms in anybody who's menopausal, but also in women who've had breast cancer. And sometimes, like I say, when they're younger or when they have treatments such as aromatase inhibitors, their menopause symptoms can be more extreme. They can be more severe than they would be if they were just having nothing just about menopause, but they were having menopause because of aging as opposed to the treatment. So we asked about the impact of menopause symptoms after breast cancer, and women were asked on a scale to 1 to 6 how much symptoms had affected their quality of life, their ability to work, and their relationships. And a lot of women had a real big impact on their quality of life and their ability to work, and a large proportion, so nearly half, rated 5 or 6 on the impact on their relationships. And this is really, really important and something that's not spoken about enough, I don't think. It can be really difficult for partners of patients to know how to talk about the impact of the menopause is happening on, or the impact it's having on them and their relationship. And it might not be just their physical and sexual relationship, it's just their day-to-day relationship. We know a lot of the symptoms such as irritability, anger, being short-tempered, being more anxious, not sleeping well. All of these can have a strain on relationships, and it's very important that partners are given information as well. Now, there is treatment available for menopause following breast cancer, and like I say, I will do another session talking more specifically about that with the data. But when we look at what people have been given, then a lot of people are given non-hormonal treatments. Some are given CBT, some are given different non-hormonal treatments, and some women are given HRT, hormone replacement therapy, because they want it to improve their quality of life and their future health as well. And in this study, there were some women who were taking HRT. There were a lot of women who were taking HRT before their diagnosis, and they were all advised to discontinue it. And some women, actually a large number, 74.6%, so 3/4 of the women, were advised never to take HRT again or refused HRT when they were asking for it. Now, it's very individualised about taking HRT following a diagnosis of breast cancer, but just to be refused a treatment that does have benefits for future health isn't involving the patient properly, really. Now, we know that people want more information, and in fact 83.7%, so the vast majority of women, wanted more information about the pros and cons of HRT after breast cancer. So when we look at quality of care, including shared decision making, this is really important. Now, some of you will have heard of shared decision making, and there are guidelines. NICE have produced guidelines about shared decision making. And anything that we do as doctors, we need to be thinking about these guidelines. And basically, it means that the patient is fully involved in any decision-making process, that they share the uncertainties, they share decision-making, and they share any risks, but also benefits. So even if me as a doctor are really deciding that the risks are more than the benefits and the treatment shouldn't be given, I have to involve the patient and decide whether they think the same as me. And it might be that a patient thinks the risks aren't as much, or they're prepared to take that risk, because they're thinking about the benefits as well. And that's not just in HRT after breast cancer, that's any treatment in any consultation. Shared decision making is really important. Now, we found here that the majority of women, 77%, could recall being counselled about the effects of their treatment, as in whether it's going to affect the relapse or the risk of survival following the breast cancer, but only half could recall being advised that the treatment could induce an early menopause, and only 36% could recall being told their treatment might have health risks, such as an increased risk of osteoporosis. When we look at the treatments that have been given, there's a graph on here, and the commonest one, you'll see this line graph, this is the commonest treatment, and this was antidepressants. We didn't ask in this study what people were counselled about regarding antidepressants, about the risks, the side effects, and so forth. We didn't go into that. But it is, in my mind, concerning that so many women are given antidepressants that do have potential risks and side effects. But there we go, half of them had been given antidepressants. So a lot of them were given some written information, but it was only 1 in 5 women, and it was usually the breast cancer nurse. Some women received written information from their oncologist, but that was only 3.2%, very small amount. And 1.3% were given information by their breast cancer surgeon, which was written. So very poor, the amount of information that they were given. Most of them had looked up on websites, on social media, books, friends and family, podcasts and so forth. But they still really wanted more information at all. They felt that they hadn't been given much time or much information, and the most information that they had was actually from a menopause specialist when they found one who could talk things through. When we looked at whether they felt able to discuss the menopause-related health concerns and the time, so very few felt that they were really able to discuss the concerns, the benefits of any treatment. So this isn't just HRT, this is any treatment after breast cancer. Most of them felt not able, rather than very able to discuss. And this chart here is looking at the time that was given to discuss menopause-related health concern. Now, this big graph here, this big bar here, shows less than 10 minutes was given to women to talk about menopause after breast cancer. Now, menopause will last forever. A lot of these women are young. I've already said it's around 1 in 5 women are young when they have a breast cancer diagnosis. It's not on, is it, that they have less than 10 minutes to discuss menopause, the consequences of it, the possible symptoms, the future health risks, the treatments that are available or could be available in the future for these women. Very few had more than 60 minutes, which is no surprise because people are time poor, but very few actually had 30 to 60 minutes. And the ones that did, in the darker bars here, were people that had seen a menopause specialist. But the breast team had very, very little time to discuss menopause with these patients in this study. And then we did looking to see how much they felt that they were shared decision makings that occurred. And for most people, made it very clear that it was the doctor who decided. The doctor knew exactly how to be, what treatment I wanted. The doctor told me that there are different options, which didn't often happen. And things like we asked if the doctor explained about advantages and disadvantages of different treatment. Very few said they were. When we asked if your doctor helped me understand the information, again, very few. The doctor asked me which menopause treatment option I preferred. They were not very involved. Only 5% of women said that that happened to them. And my doctor and I selected a treatment option together. This is what should happen in shared decision making. But around 10% actually were selected a treatment option together. My doctor and I reached an agreement how to proceed. Very few. So most of them felt that they had no involvement at all with their treatment choices. And that's any treatment. So very few women are really being listened to. Now, we also wrote another paper on the same study, and this was a thematic analysis of the comments. So, in the questionnaire, lots of people wrote comments about how they were feeling. And we looked at this and we analysed it properly to work out if there were any themes that were going on with these poor women who were not being listened to and left to really get on with it and to almost put up and shut up, to not being involved, to not having a discussion, to not having enough knowledge and information as well, and also not having the shared decision making. So what we found was that there were about 10% of women had left comments. So obviously we don't know whether this is representative of most people, but it's certainly the women that we see in our clinic really tell us very similar stories, and the stories that I hear in my clinic haven't got better over the last 10 years. They're still coming, and people seem very scared of talking about menopause to breast cancer patients because they feel that they might have to have a conversation about HRT and they're too worried about it. But having a conversation is not the same as treating. It's not the same as writing a prescription. It is just talking about it. We need to remember there are different types, there are different doses of hormones, and also there are different ways of having them. Women with breast cancer often have localized symptoms of vaginal dryness, soreness, irritation, urinary symptoms as well. And in fact, we found in this study 71% of women had symptoms related to genitourinary syndrome of menopause. But only 35% of women were given vaginal hormones. Now, we know vaginal hormones are usually very safe in women who've had breast cancer, even women who've had estrogen receptor positive breast cancer, because they don't get absorbed systemically in the body. So they are very low dose, they are very effective, and yet the majority of women aren't receiving them. So there are some free text comments here, which I thought I would share with you. A lot of people found that any attempts were met with complete refusal, any attempts of trying to receive treatment. One lady said she wanted HRT and it took her GP 4 years to make the diagnosis, to actually agree to having HRT. She said it was an endless and complete disregard for the quality of her life. A lot of women were doing their own research and they were having to persuade or battle with clinicians to get HRT prescribed for them. One lady said, "What a battle when I had been through so much, was feeling so unwell. I honestly wanted to die. It was so awful." One lady said, "I met a well-informed senior practice nurse 9 years after my surgery. She helped me get a response from my oncologist and I've started the treatment I want." However, one lady said that her consultant said that anyone who prescribes her HRT after breast cancer should be struck off, and no reputable doctor would give HRT to another lady who had breast cancer. Now, again, I'm not saying here that women with breast cancer should or shouldn't have HRT, because the evidence is actually quite poor either way. But what I am saying is that women deserve a choice. If they are consenting adults, if they're aware that there may be risks, but also know that there are benefits to treatment, they can decide. So to actually say a doctor should be struck off is wrong. It's absolutely wrong because it's not putting patients central. One doctor said he wasn't prepared to lose his 40-year-old career over prescribing me HRT, and that was the end of the discussion. Again, this is actually very barbaric and very obstructive. Women are really struggling to be listened to and struggling to receive a choice. There are benefits of having various treatments and there might be risks, but we should be listening to our patients and allowing them to choose. I have no idea what it's like to have had breast cancer. I have no idea what it's like to have treatments that cause menopause from breast cancer. I know what my menopause and perimenopause was like, but it's not the same for everybody. So I don't know what it's like to be menopausal having had breast cancer. And these individual women do, and they should be listened to. One lady said, "It makes me incredibly angry that none of the medical team explained about early menopause and what symptoms I might experience. I've always been confident and enjoyed life. It completely broke me, and when I challenged the medical team, they just said everyone has different experiences. I asked why they didn't give all women going through this treatment a leaflet explaining they might experience so women could be prepared. The team said everyone has different experiences, so we don't give out information." So that's really sad, isn't it? Um, so many people are uninvolved, and we know that sharing uncertainty with patients will improve trust. It will also help make a better consultation, and also be, above all, it will empower patients and improve their satisfaction with care. If you are a patient or a woman who has had breast cancer and struggling to receive information about menopause, there is a lot of information available. I've done various podcasts about breast cancer from women who have been patients, but also with an oncologist, with a breast surgeon, with a medical menopause specialist who has written a lot about this and knows a lot of the evidence as well. So there's quite a few podcasts I've done, and there's also a big article on my website for women who've had breast cancer as well. So having information about symptoms, what menopause means, what it means if have had two menopauses, and also about treatment choices, both hormonal choices and non-hormonal choices, and about being fully empowered so you can make the decision that's right for you. What I really wanted to get out of this session was just explaining about how women are really feeling that they're not being listened to and they're not being given information, rather than focusing on the treatment that they want or was trying to get or couldn't have. It's more than that. This is really just about women being listened to and women being involved in any decision making. So it's not just really for women who've had breast cancer. Any woman or any man, any patient deserves to be listened to. So there are a few things that I think are useful. One is having information, getting available information that is not biased, so not written by people who have involvement with pharmaceutical companies or have their own agenda, making sure that the decisions you make are right for you as an individual, and then maybe involving someone else. Have someone who works as an advocate for you, whether it's your partner, whether it's a good friend, it could even be a work colleague, it could be another relative. But let them come to your consultations with you so you can really work together and be fully empowered and knowledgeable. Maybe seek out someone else, maybe get a second opinion, maybe see a menopause specialist and go to see your menopause specialist with all the information from your oncologist. So when we see people in the clinic, we ask women to bring their notes and records that they have had from their oncologist so we can go through things together. Often, as doctors, we work as a team, so we will discuss with other doctors and other clinicians and really build up a picture that's right for that individual patient. So, if you feel you're being treated as a number or not as an individual, go and see someone else. It's absolutely fine to get a second, third, fourth opinion because your menopause will last forever when you have it when you're older. If you have it as a part of treatment, yes, it might only be a few years, but that's still a few years of suffering potentially. So, being fully armed with information and knowledge, finding someone that you can really talk through properly so you can be fully involved in any treatment making decisions is crucially important. If you don't feel that the person that you're seeing has enough knowledge and experience about menopause, go to a specialist menopause clinic. Go and find someone who does understand and know that any decision you make regarding treatment, you can change your mind. You can stop the treatment, or you can start it at another time, or you can change your mind and try a different treatment as well. It has to be really fluid and flexible, but the most important thing is that you are essential to any conversation, any treatment making decisions, which hadn't been highlighted in the results of this study. This study showed the complete opposite, that women are being neglected, they're being spoken down at, they're not being involved in in the sort of patient sharing decisions, and they're really not being involved in treatment choices or given the right information either to make those decisions. So I hope that's helped. I will put the links to the two articles on my stories, and they will be available. So, and they're freely available through PubMed, so people can read the full articles. But I hope if we repeat the survey in a few years' time, experiences will be a lot better. And more oncologists and cancer specialists are getting involved in education about menopause. But we've got a huge way to go before every woman who's had breast cancer feels that they're given information and have options for treatment to improve their menopause symptoms and their future health as well. So thanks for joining, and speak to you soon.